Hello, and welcome back to Paul Harton Explains Episode 2. This week we are going through an article with the title of The Abuse Potential of Medical Psilocybin According to the 8 Factors of the Controlled Substances Act. Before I go through the article for you guys, I just want to explain a few things. I did not write this article, and lastly, it's for educational purposes only. The title, The Abuse Potential of Medical Psilocybin According to the 8 Factors of the Controlled Substances Act. This article was published in 2018 by, it seems, four authors here. We have Matthew Johnson, Roland Griffiths, Peter Hendricks, and Jack Henningfield. Roland Griffiths appeared on Jordan B. Peterson's podcast, Season 4, Episode 20. In case you guys want to check that out, I forget the year that it came out, but it's a really cool conversation, which I invite you guys to check out. All right. So the contents of this article is really cool. Obviously, they say they break it down into 8 factors. I'm just going to read off the factors here for you before we jump into them. Factor 1, we have actual or relative potential for abuse. Number 2, scientific evidence of its pharmacological effect. Number 3, the current scientific knowledge regarding psilocybin, the history and current pattern of abuse. Number 5, the scope, duration, and significance of abuse. Number 6, you have the risk to public health. Number 7, psychic or physiological dependence liability of psilocybin. And factor 8 is the immediate precursor of substance control. And then they have the discussion and whatnot. Okay, so the title of the article contains the words, the Controlled Substances Act. And if you are not familiar with what that is, I'll give a brief explanation here. Basically, you have all the drugs that exist in the world, whether it's alcohol, marijuana, nicotine as in cigarettes, different things like that. And they put them in these categories, Schedule 1 to Schedule 5, about how dangerous they are, how addictive they are, how likely they are to be abused, if there's any sort of different new medical literature about medicinal properties, if they have any medicinal use. The schedule that they're put in is supposed to reflect that. So in Factor 1, titled Actual or Relative Potential for Abuse, go into some detail talking about how they do need more studies about the actual addictive qualities, if any, of psilocybin. They talk about how in 1956, an article published by Isbell, ISBELL, they took human volunteers with history of substance abuse and they evaluated them for the potential euphoric effects of psilocybin. However, they actually didn't assess for the 2 main important parts of addiction, which is physical dependence and withdrawal effects. Then that kind of led into a whole other area where they talk about how the differences that LSD and psilocybin, the differences and effects that it makes the individual feel, things like fear and anxiety at certain points, that helped them develop a new scale called the dysphoria and psychometric scale, which captured fear and anxiety and seemed to predict low abuse potential. They talk about the setting of these new studies, so cited in 2016 by Griffiths et al., Ross et al., and Johnson 2008, they are aiming at giving their participants the best experience. So they're trying to make it the most pleasant experience that can happen, which means that you're more likely to see results of euphoria and, apparent pleasure, confidence, sense of well-being, and which was considered in 1956 as potential for abuse. Alright, so next up we have Factor 2, which is the scientific evidence of the drug's pharmacological effect. So they talk about how there's been more than 1,000 scientific and clinical studies using classic psychedelics such as LSD and psilocybin, published through the 1960s. They even cite the Drug Enforcement Administration, so the DEA, in 1995, and they say several thousand more have been published since the 1960s, and they cite Sellers et al. They talk about the LD50, which I'll put right here. If you don't know what the LD50 is, you'll be able to see that. And essentially they say the LD50 is 250 milligrams per kilogram of body weight. And a kilogram is 2.2 pounds. So I'll do a quick math problem here so you can see how much intravenous psilocybin it would take to kill Paul Explained. They cite Sleretti in 1958 for that fact there, and they cite Gable et al. lethal dose in humans has theoretically been estimated at approximately 1,000 times an effective dose, which is an amount that is likely not possible to consume when in the form of psilocybin-containing mushrooms. Next, they move on to a point that says individuals with serious cardiac vulnerability should be excluded from any future studies. Alright, so next up we have Factor 3. The title of Factor 3 is the current scientific knowledge regarding the drug. They say, however, there is no well-documented theory about how such acute effects lasting only hours can lead to therapeutic benefits lasting months and possibly a year or more. They do show this graph that I'll pop up here. You have massive differences between, on the top you have stuff that's going on with your heart, stuff you really want to prioritize and pay attention to, and it's good that they did that in Griffiths et al. In 2016. So as you can see, the differences between systolic, diastolic blood pressure and your heart rate are pretty large when you compare the high and low doses, with the heart rate kind of varying between the high and low dose. I mean, about 5 to 10, maybe max 15 BPM during the entire experience. And then you have, on the bottom row, you have massive differences in all of the drug effect rating areas. So you have your drug effects, your visual effects, and then joy, intense, happiness scales. And those are all drastically different when you compare the high and low dose. After Factor 3, we are on to Factor 4. And Factor 4, I will pop up an image so you fine folks can look at it. And the last point here about of Factor 4, we have that Albert Hofmann discussed the medical potential of using very low doses of LSD for antidepressant effects as early as 1976, and it was cited by Horowitz in 1976. So we have Factor 5. Factor 5 begins with a quick table 6, and they give a brief little table there about the estimated drug percentages of the reports that were submitted to the labs for about 5 years, and this graph came from the DEA in 2011 to 2016. And they do talk about, obviously summarizing these sections here, they talk about first how drugs like alcohol, cocaine, and opiates have been used for thousands of years. However, they were, these drugs are recognized and known as addicting and harmful to many of the people around them, not only the users. So, I mean, you have a citation from 1808, but they talk about how the misinformation and misunderstanding of the actual risk and harms of psychedelics during the 1960s was all misinformation, or a large portion of it was misinformation due to social lore, sanctionized media coverage, even though experienced medical practitioners showed that these drugs were remarkably safe. The main reason it was put in Schedule 1 was misinformation and lack of research. Next, Table 7 in Factor 5, I'll pop up here for you so you can look at that. The stuff I've highlighted in green is the stuff I want you guys to look at. 2007 to 2015. And this is the Poison Control Center. The number of cases that mention mushrooms, 473 to 758 for an 8-year period. When you compare that to alcohol, you're looking at 47,000 to 54,000 cases that are mentioned. And, cocaine, 4,200 cases to 7,600 cases. Next up, right before Factor 6, they give a really good breakdown of another graph. This graph, I find it to be a very good visual. On the axis on the left, you have the overall harm score. You have your key in the top right, harm to users and harm to others. And then on the bottom, you have all your listed drugs. All your listed drugs: alcohol, heroin, crack cocaine, methamphetamine, cocaine, tobacco, amphetamine, cannabis, ketamine, and then as you see, LSD and mushrooms are very on the far right. So Figure 3 description is normalized ratings of harm potential of psilocybin relative to other drugs, rated by experts in the UK. In Factor 6, after the risk to public health, we get to the potential public health benefits. There's 3 points here I want to make. The first point is they mention the study that we reviewed on episode 1, so if you haven't seen that, I recommend you watch that. It's really interesting. If you get something out of it, let me know, make a comment, like the video. They talk about how psilocybin can be useful with treatment-resistant depression. They also talk about how it can be useful for the treatment of depression and anxiety to improve the quality of life, like in life-threatening cancers. And lastly, they do talk about how it can be used to cause significant increases in interpersonal closeness, gratitude, meaning of life 6 months after a psilocybin administration. This next graph that I'll pop up there is also really interesting because they go through a slew of different things. And I will say that those stars indicate a significant difference between the low and high dose. And as you move through the graphs, you can see that your low dose is in blue and your high dose is in red. So we have 2 more points here, then move on to 7 and 8. That found that lifetime classic psychedelic use was associated with a reduced risk of past year opioid dependence and past year opioid abuse. Next up, lifetime classic psychedelic use was associated with a reduced odds of past year larceny, past year assault, past year property crime, and past year violent crime. Okay, factor 7 is psychic or physiological dependence liability. And this section is pretty small, but the major conclusions are yes, tolerance exists, and no dependence and withdrawal have not been documented. So factor 8 right after factor 7 is just like a sentence, and it says psilocybin is a prodrug to the active entity psilocin, both which are currently placed in Schedule 1 of the CSA. For the last and final wrap up here, we have the discussion. So we are all completed with the 8 factors. Now we're on to discussion. We get to see what they want to say about all this data. While they do say it's an abbreviated assessment, the findings do not support placement more restrictively than Schedule 4. They do say that they will include at least one major Phase 3 clinical efficacy and safety trial that indicates assessments relevant to abuse potential. They cite Calderon et al. 2017 and Sellers et al. In 2017. The CSA stipulates that Schedule 1 is for substances with high potential for abuse, lack of therapeutic approval, and cannot be used safely in medicine. History of use and available scientific data show that the first criterion is questionable, the third criterion is likely not true, the second of this criteria can be negated by the FDA approval of psilocybin-containing products, but at this point the data suggests that the potential therapeutic benefits of psilocybin-assisted therapy are real. Potential medical and public health significance. That's basically it. That concludes the abuse potential of medical psilocybin according to the 8 factors of the Controlled Substances Act, released in 2018. So I really hope you guys like this. I tried to shorten it for you, tried to give you, really nice condensed versions of all this stuff so that you don't have to spend a half an hour watching these videos. You can pop them on before bed or something like that, whatever works. So if you liked the video, make sure you like the video, subscribe for more, share it with your friends, send it to your grandma. Alright, see you later.